Welcome friends to Raaonline coaching. Today's topic is acetaminophen toxicity. Okay, so way back in 1800s, where the world was in war, pain and sepsis fever was on a very high trend, and the only components available to control this were the phenacetin and acetylenide. These had severe side effect, that is methemoglobinemia. The active principle for these two compounds is actually the N-acetyl para-aminophenol. They were not able to extract this for nearly 70 years. Only by 1878, they were able to extract this active principle. So after nearly 170 years of struggle, it became first used in 1950 and accepted in 1970. This is because of the fear of the methemoglobinemia which the parent compound had. So we have this wonderful drug called as paracetamol. Hope you are aware that billions of paracetamol are being sold worldwide per annum. So how does this nomenclature come up? N-acetyl p-para-aminophenol is abbreviated as APAP. We call it as acetaminophen because of this nature, acetaminofen, and in India we call it as paracetamol because par-acetamol. So this is the nomenclature. So before the mechanism of action, we should be aware that the analgesic action is at around 10 micrograms per ml and antipyretic action is around 4 to 18 microgram per ml in the blood. So here comes the phospholipids which is there in the cell wall during times of inflammation lets out arachidonic acid. So this arachidonic acid is acted upon by an enzyme called as COX. Okay. So this COX enzyme and this peroxidase both belong to the same enzyme group. This is called as domain 1 of the enzyme COX. This is called as domain 2 of the enzyme COX. Okay. So cyclooxygenase acts on arachidonic acid, converting it into PGG2. And then comes the peroxidase, which turns this PGG2, which is an intermediate compound, to a PGH2, which later gives you all these prostaglandins, which is responsible for all the inflammation and pain. So giving a detailed picture, this is a cell membrane. So once the inflammatory stimuli sets in, phospholipase A2 acts on the cell membrane, letting out arachidonic acid. So this is acted upon by COX1 and COX2. Usually NSAIDs act over this COX1, COX2. This is the A domain of the COX. This is the B domain of the COX. It is this way this paracetamol is different from NSAIDs. Both are COX inhibitors, but NSAIDs attack at the COX1 or 2 region. But paracetamol attacks at the POX region. Okay. So arachidonic acid is converted into PGG2 by COX1 and COX2, and PGG2 is converted into PGH2 by POX. So this peroxidase enzyme is the substrate for your acetaminophen. This peroxidase enzyme has a ion group. This ion group is reduced by paracetamol, reduced by acetaminophen. It is by this reason the POX is made unstable and this get arrested at PGG2 itself. Okay. So now having said that paracetamol acts as a reducing agent of this POX. Now where can this function better? Where there are no oxidizing agents, paracetamol can function better. Where there are more oxidizing agents, this paracetamol, which is a reducing agent, cannot function better. It is for this reason in peripheries, that is in the blood in general, there are a lot of lipid peroxidases, especially the macrophages, the neutrophils, which are very high in peroxidase enzymes. It is for this reason the action of paracetamol in the peripheries are very, very limited. But in the central nervous system, where the oxidases are very, very limited, paracetamol has a significant action. Okay. Coming to the pharmacokinetics, the liquid formulation time to peak is 30 minutes. If it's a tablet formulation, it's 45 minutes. Extended release formulations do occur and it is 1 to 2 hours. If it's rectal, 2 to 4 hours, and IV, it's less than 15 minutes. And please be aware, these can be delayed by food, opioid, antimuscarinics if taken orally, not by IV. And it's around 10 to 13% protein bound. Less than 2% of what is given to the patient can be secreted in the breast milk. Okay. So pharmacokinetics, paracetamol, the major metabolism goes through Either the glucuronidation or sulfonation, around 90% happens through this. Some 2% goes unexchanged in the urine itself. Only around 5% is acted upon by this cytochrome P2E1 enzyme. This enzyme creates this active metabolite, a toxic metabolite, which is called as NAPQI, which we call as NAPQ. So once the NAPQ is formed, it has two fate. One, this GSH can convert this NAPQ into a non-toxic metabolite. And if the glutathione GSH is depleted, there is no other fate for NAPHQ, this goes and attacks your hepatocytes. So when you give paracetamol to a patient, if there is adequate glucuronidation and sulfation, yes, maximum amount of metabolism goes that way. 2% exchange in the urine, 5% goes to this particular enzyme, which creates NAPQ, and a significant amount can be taken up by the glutathione reserves. And if glutathione reserve is decreased, then this NAPQ affects your hepatocytes, and that is when the liver injury starts. So coming to the pathophysiology, we must understand that GSH, the glutathione reserve, the active reducing agent, need not be zero for a NAPQ to affect the liver. If it's reduced to 30% itself is more than enough, the NAPQ binds to the protein particles of the hepatocytes, producing something called as protein addex. And this is the main culprit of this entire pathophysiology. So here comes, the NAPQ binds to the mitochondrial proteins. Then activation of kinases, it could be MAP kinase or the junk kinase. So once it is activated, kinase is making a cutting device, right? Once a cutting device is activated, a lot of pores get formed in the mitochondrial permeability membrane, right? Once the pores are formed, the permeability increases. Once the permeability increases, there is decreased mitochondrial respiration and decreased ATP synthesis, okay? So further, opening up, meaning the cleaving of this mitochondrial membranes, releases this endonuclease G apoptosis inducing factor, topoisomerase 2A inhibitors, and thus causing DNA fragmentation and cell necrosis. So once the cell gets injured, it activates the injury of the surrounding cells also. There are certain proteins called as DAMs, damage associated molecular patterns. These get released in the blood, which has the potential to activate an inflammatory cascade, which can damage the surrounding hepatocytes also. By what mechanism? It actually activates the toll-like receptors on the Kupffer cells and further activates the cytokine and nitric oxide storm, so that this goes as a cycle affecting more and more hepatocytes. So what are the clinical manifestation? Stage 1. Please be very sure, dear friends, stage 1 is usually asymptomatic. Most of the patient, more than 95% of the patient you are seeing is going to be asymptomatic because hepatic injury has not yet occurred. Patient might have some nausea, vomiting, malaise, and pallor and diaphoresis. This is only for 95% of the people. But if your patient has consumed a massive overdose, without even evidence of hepatic injury, patients can have decreased level of consciousness, metabolic acidosis, and even death because of acidosis itself, without any hepatic injury, even in stage 1. So why this is put particularly in stage 1? Stage 1 is specifically without any hepatic injury, okay? So I'm emphasizing on the fact that without hepatic injury in heavy dose of paracetamol poisoning, a patient can even die just because of metabolic acidosis. This is because of elevated lactate, which is caused by the inhibition of electron transport chain directly by this APAP, which is the paracetamol or its metabolite,